I want to give today a collection of cases, angiographic and hemodynamics. This is a right coronary angiography in an LAO view. This is an epicranial view of the same coronary. And this is an RAO view of that same coronary looking well at that mid-RCA where the disease is. The patient has angina. Should we try to wire this and stent it? The reason I'm showing this angiogram, it's a very important angiogram that can fool experienced interventionalists. The biggest mistake you can make in this case is to go through that channel that you see here, wire it, balloon it, and think you can stent that area, thinking that this is a true intimal channel. Wrong. This is a complete CTO. This is 100% occlusion. This is not 80 or 99%. The channel you see here is actually a bridging collateral. This is not an intimal channel. You should never try to wire this, balloon it, and stent it. If you wire this and try to balloon it, you will end up with a huge perforation. This is a flimsy, adventitial bridging collateral. Whenever you see an angiogram like this, you can think of two extremes. Either a functional CTO and the channel you see here, is actually true intimal channel that you can wire and balloon and stent, and that's the easy option. The second option is the other extreme. You have a CTO, 100% occlusion, and what you have here is a bridging collateral that will make it actually a complex CTO because it will make your cap ambiguous, and each time you try to cross the CTO, your wires will tend to go into that branches. And those are cases where to cross the CTO, you need to do a technique called move the cap, where you need to go do either scratch and go proximally, create a dissection proximally, and go behind that area so you avoid that bridging collateral, or you may do something called base, where you do balloon-assisted subintimal entry. Again, you create a dissection proximally on purpose, and you go through the dissection plane to avoid going into that flimsy branch. So when you see something like this, it's one of two extremes. Either a functional CTO with an intimal channel, or the other end, a very tough CTO with a bridging collateral. And this is the latter here. And you make the mistake of wiring this and ballooning it, you'll end up with a huge perforation. Now, how can I tell this? Partly with experience, but the path it follows, including the way it joins the lumen at the very end. And you can see here in an RAO view, you see how it tries to join the lumen. It has a bend, almost a kink, before it joins the lumen. It goes like this, then it bends and it joins the lumen. That tells you that's not the true intima. The true intima is more straight. This one is doing a very sharp two bends to get back into the lumen. So this is a bridging collateral. It's around the vessel, not inside the intima. It's in the adventitia. Another thing that is a hint is that usually it's not the only bridging collateral. There are a lot of flimsy vessels around it. So whenever you see something like this with a lot of flimsy vessels around it, this is likely to be bridging collateral, not a true intimal channel. Another thing is, if it was a true intimal channel with antegrade flow, why would you have so many channels and bridging collaterals around it if it is a good intimal channel providing decent flow? Why would the flow here from the acute marginal, look at it, the acute marginal is feeding the distal vessel faster than this antegrade flow, which tells you that those are likely collaterals like that acute marginal. This is not a true intimal channel. So all this picture tells you this is a collateral. This is not an intimal channel, like that acute marginal, which is a collateral, like the other flimsy branches, which are collateral. That caput medusa, morphology of that stenosis suggests this is a complete CTO and those are bridging collaterals, and you should not wire those. Again, look at that bunch of flimsy caput medusa around that area. Very important, because the fellow with me here wanted to wire and stent this. No. This is another case. This is a tracing obtained during a right heart catheterization. Tell me, this is from which chamber and what is the diagnosis? You need to recognize this immediately as you look at it. This is actually pulmonary capillary wedge pressure with a massive V wave. This waveform has a peak pressure of 65. You may think it's PA pressure, but it is not, for the following reason. It is upsloping between the peaks with an A wave, whereas PA pressure would be downsloping between the peak with a dicrotic notch earlier on. So this is not a PA pressure. Number two, the PA pressure doesn't have that peaky morphology, that narrow peaky morphology. The PA pressure is wider looking and peak throughout the STT segment. And the PA tends to have a sharp upslope with a slower downslope with a dicrotic notch. Whereas the V wave of a high wedge pressure will be peaky, narrow like this, peaking after the T wave. So for those reasons, the morphology, whether the morphology of the peak, the narrow peaky morphology, or the morphology in between the peaks, suggests this is definitely not PA. This is likely a wedge pressure with a huge V wave. Now, could it be RV? The morphology in diastole could be RV, that upsloping with an A wave. However, again, in systole, the RV is not peaky, narrow like this. The RV will be more rectangular, plateaued. It peaks throughout the STT segment. So this is not an RV morphology. Could it be RA? It's very hard for the RA to have such a high V wave. And when you have big V wave with an RA pressure that is secondary to TR, you will typically have what we call a ventricularized RA morphology. The V wave will not only be big, it will also be wide. So this cannot be an RA. This is a wedge pressure with a huge V wave. And what do we call a large V wave? Large V wave means V wave that is 10 millimeter or more above the mean of the wedge pressure. That's the definition most often met. Another definition is V wave over 50 millimeter of mercury. And the third definition that is more difficult to meet is V wave more than twice the mean. And when you meet that third definition, V wave more than twice the mean wedge pressure, especially more than 2 to 2.5, this is what usually suggests severe or massive acute mitral regurgitation. When you meet the other two definitions, V wave more than 10 millimeter above the mean or over 50 millimeter of mercury, the most common cause of that large V wave is actually decompensated heart failure, overwhelmingly. That's the most common cause of V wave in practice. Only when it's massive like this, it suggests severe decompensated mitral regurgitation. Most large V wave are not MR, and most MR don't give big V wave. They need to be decompensated inpatient in pulmonary edema to have that big V wave. And this is what this patient had. And here is a comparison in this patient of the PA pressure versus the wedge pressure. And note the difference in morphology. The PA pressure is wider and it has a sharp upslope with a slow downslope and a dicrotic notch. Whereas this one has equal slopes up and down, particularly that sharp downslope, which is opposite to the slow downslope of the PA, which has also dicrotic notch. And in diastole, it's upsloping versus downsloping for the PA. Interestingly, this is a rare case where the V wave almost matches the systolic PA pressure. That's very rare. You rarely get such a big V wave. This is a case where the PA flow will stop and end systole because of that massive MR competing with it. And this is also one of those cases where the mean wedge pressure is actually higher than the PA diastolic pressure. It's never higher than the mean PA pressure because then you'll have retrograde flow throughout the cardiac cycle. It's impossible. But the mean wedge is higher than the PA diastolic. It's never higher than the mean PA. Normally, in overwhelming majority of cases, the mean wedge is lower than the PA diastolic or equal to the PA diastolic. In diastole, the diastolic wedge is actually lower than the diastolic PA. So we have forward flow in diastole. It's just that the mean wedge is higher than the diastolic PA. In those cases with massive MR and massive V wave, where the mean wedge is driven by that big V wave in end systole. And sometimes that V wave is so big in end systole and it competes with the PA flow and it causes a bump on the PA waveform. You may have here a bunny ear on that PA waveform. This is another case. What is the chamber in that case? This is the exact same thing. This is a wedge pressure with a massive V wave. Again, narrow, peaky wave, peaking after the T, with horizontal or upsloping intervals in between the peak, with a wave in between the peak. This is not a PA, this is not an RV. This is a wedge pressure with a massive V wave. Again, likely decompensated mitral regurgitation, although it could also be severe heart failure, less likely when it is that big, more than twice to 2.5 times the mean wedge. And this is in this patient, the wedge pressure versus the PA. Again, look at the PA. It's wide and it's peaked throughout the SCT. It has a slower downslope, sharp upslope, slower downslope versus a peaky V wave in a wedge pressure with a sharp downslope. This is another case. This is a simple coronary angiogram case. And this is the aortic waveform during that case. What's the diagnosis when you look at this? What does this aortic waveform suggest? This waveform suggests severe aortic stenosis. Notice, unlike a standard aortic arterial waveform, normally the upslope is sharp and the downslope is slow with a dicrotic notch. In this patient, the upslope is sluggish and has a bump low on that upslope. This bump here that we call anacrotic notch as opposed to the dicrotic notch. You have a low anacrotic notch low on that upslope. This is suggestive of severe aortic stenosis, and this is what we call the pulsus tardus. That aortic waveform has a slow upslope and is peaking late. And the anacrotic notch is explained by the fact that the valve initially opens and then it hits that flow limiting aortic valve area. It hits that 0.7 centimeter square, then it doesn't open anymore. Then the aortic pressure starts to rise slowly because the valve is no longer opening. Furthermore, you get attenuation of the dicrotic notch. You can get attenuation of the dicrotic notch in AI, especially acute AI. You can get it also in severe AS, assuming that that waveform is properly damped. You don't have a blood or contrast in your tubing. So this is very suggestive of AS. There is something unusual though. When you have severe AS, you get pulsus tardus, you know, that delayed peaking with low lying anacrotic notch. But you also get pulsus parvus, meaning a narrow pulse pressure from the narrow stroke volume. This is a wide pulse pressure. The pressure here is around 155/75. So how come you have wide pulse pressure with this AS? What's the diagnosis? There are two options for wide pulse pressure with AS. One, it's an AS in an old 80s, 90s years old patient who has a very non-compliant artery, where even a small stroke volume may lead to a wide pulse pressure. That's why that pulsus parvus may not be seen in old patients with severe AS. Another option is you have mixed AS-AI. So you have some degree of aortic regurgitation with it. Note that patient with severe AI may also have anacrotic notch. So because severe AI can create a functional AS, especially when severe AI is associated with mild to moderate AS, that aortic hole in systole is functionally obstructive for the high flow that is recrossing that aortic valve. So you get a functional AS and you get an anacrotic notch, except when you have a predominant AI with some AS or with functional AS, that anacrotic notch will be high lying, will be lying up on that waveform, not so much down. That's why this is predominantly severe AS with either some degree of AI or non-compliant peripheral arteries. This is another angiographic case. Look at this angiogram here. This is an areocaudal view. What is unusual? What do you see? You see here a fistula. You see a vessel filling a chamber, and that chamber quickly empties. You see a communication between that first septal and the cavity. This is a coronary cameral fistula. Now, this is an areo view that separates the ventricles on one side and the atria on one side. So this is a coronary cameral fistula between the first septal and a ventricle, most likely, statistically speaking, the right ventricle. And this is another view of it here in an areocranial view. You see that long septal, and it's emptying in a cavity here. Look at it, and it's emptying in a cavity here. Again, it's on the ventricular side in an areo view. You have the AV groove where the circ is, and this is on the ventricular side. Whenever you have a fistula, always remember to use your two views. Areo looks in this direction into the AV groove and sets apart anterior structure, which are the ventricle, and the posterior structure, which are the atria. LAO looks over the septum and sets apart right structures versus left structure. The same way when we engage left cusp versus right cusp. So in this patient, in order to confirm where that fistula is landing, we need to do an LAO view and confirm that it is indeed in the right ventricle, not into the left ventricle. But unfortunately, in this case, I don't have an LAO view, but overwhelmingly, it is in the right ventricle. Most coronary cameral fistula land on the right side of the heart, and most frequently the RV, then the RA. Only 3% terminate in the LV. And this may not even be a septal. It may be the fistula itself between the LAD and the right ventricle. This may be the fistulous tract rather than a septal, because we don't see those ramified branches into the septum from that artery. What's interesting is that the echo in this patient showed what seems to be a possible small VSD. There was some color flow in the right ventricle. It wasn't a VSD. It was actually that coronary cameral fistula into the right ventricle. And this is a simple fistula. It's one track, and importantly, the vessel upstream has not become aneurysmal. If this was a large fistula with hemodynamic effect, the upstream vessel here, the left main or the proximal AD, will have become aneurysmal. So that's unlikely to be a hemodynamically significant fistula, and you can prove it via right heart cath, a lack of O2 step up.